Hello, in this next type 2 diabetes upskilling video in collaboration with the medicines management team, I'll be covering one size does not fit all, individualizing HbA1c targets for our patients living with type 2 diabetes. I'll be discussing why it's important that we are not too glucose-centric in our approach to type 2 diabetes. We must challenge ourselves as clinicians, as pharmacists, GPs, nurses in primary care. What is our goal of treatment? Is it quality of life or quantity of life, or indeed both? This brings to mind a favourite quote of mine, originally thought to be attributed to Abraham Lincoln. In the end, it's not the years in your life that count, it's the life in your years. For those I've not had the pleasure of meeting, I'm Fernando, a portfolio GP working within NHS Lothian near Edinburgh. I've had a long-standing interest in all things diabetes and, of course, all things now cardiovascular, kidney and metabolic. I also work 1 day a week for Medscape Global and UK as a content advisor, creating independent medical education content. I'll show you some of that just shortly. And I'm an honorary clinical reader at the University of Dundee. I'm also very active on social media, particularly LinkedIn, and I have a patient-facing YouTube channel with some short, sharp videos aimed at people living with type 2 diabetes, covering lifestyle and type 2 diabetes, SGLT2 inhibitors, and I've recently filmed some videos covering the incretin therapies, the GLP-1s and the GLP-GIPs. These are my disclosures for 2025 to 2026. But of course, today's presentation is completely independent from the pharmaceutical industry. So these are some of my resources that I've put together with my Medscape Global hat on. These can be downloadable via these QR codes, or feel free to get in touch with me and I can email you copies as well. First one is the diagnosis and classification of diabetes in primary care. Not all diabetes is type 2 diabetes. So in this primary care hack, I cover type 1 diabetes, LADA, latent autoimmune diabetes in adults, monogenic or genetic diabetes, gestational diabetes, and type 3C diabetes or pancreatogenic diabetes. I cover some diagnostic pearls and pitfalls to avoid. The next one, I cover pre-diabetes or identifying people at high risk of type 2 diabetes, drawing on nice guidance, public health guidance in particular. Chronic kidney disease, very common alongside type 2 diabetes. And we need to be aware, once EGFR drops below 60, we may need to dose titrate certain medications. So I've put together a little visual guide on the pharmacological management of hyperglycemia in people living with type 2 diabetes and chronic kidney disease, covering all the major drug classes and what to do with their dosing according to EGFR. So please do have a look. And the final one, SGLT2 inhibitors. SGLT2 inhibitors are now the norm, really, for the majority of people living with type 2 diabetes. But as many of us now know, we're now using SGLT2 inhibitors for people with and without type 2 diabetes. So I put together a quick little guide on the extraglycemic indications of SGLT2 inhibitors. And my final plug, if you don't mind, if you'll indulge me, my YouTube channel, as I briefly mentioned. As already I've mentioned, I cover SGLT2 inhibitors for people living with type 2 diabetes, importance of urinary ACR testing. I did that video in conjunction with Kidney Research UK, and a series of videos about the importance of lifestyle, positive lifestyle choices for people living with type 2 diabetes. Feel free to signpost to your own patients if you think that might be helpful. Okay, let's go to the main event then. HbA1c targets in type 2 diabetes. Now, there's no doubt hyperglycemia is central to both microvascular and macrovascular disease. And this is across the spectrum, actually, in people living both with and without diabetes. Any degree of hyperglycemia can increase the risk of both micro and macrovascular disease. And we know hyperglycemia is an independent risk factor for cardiovascular disease. And that's because hyperglycemia, high blood glucose levels, damages the endothelium in blood vessels, leading to oxidative stress and the release of free radicals, and also leads to low-grade inflammation within blood vessels, leading to an increased risk of plaque formation and atherosclerosis and subsequent atherosclerotic cardiovascular disease, such as heart disease and stroke disease. However, there's no doubt what evidence tells us over the years, we have been too glucose-centric in our approach to type 2 diabetes care. One size does not fit all. This has partly been driven by QOF, which has set HbA1c targets for point attainment over the years. But equally, we need to take that holistic, person-centered approach to the management of type 2 diabetes. We need to treat the person, not the number, not the HbA1c. And this brings to mind another favourite quote of mine from the late great Sir William Osler, the Canadian physician. The good physician or pharmacist or nurse treats the disease. The great physician treats the person who has the disease. So you can see again, we must take that holistic, person-centered approach to the management of type 2 diabetes. So let me take you through some of that seminal evidence that allows us to bespoke HbA1c targets in those living with type 2 diabetes. I'm going to draw on the seminal UKPDS, the UK Prospective Diabetes Study, originally published in the late 90s in the Lancet, that really on this study, much of our modern diabetes care is based. Now, don't worry, I'm just going to give you some top-line messages relevant to us all working in primary care as pharmacists, GPs, and nurses. So who did the UKPDS recruit? They recruited a younger group of individuals newly diagnosed with type 2 diabetes, mean age just 53 years of age. And this group of individuals was randomized into two groups according to their weight, overweight or near normal weight. And then each of these groups again were randomized either to tight glycemic control, aiming for a fasting plasma glucose of less than 6. So this study started way back in the late 70s. So this was before there was widespread use of HbA1c. So the tight glycemic group were aiming for a fasting plasma glucose of less than 6 or diet intervention alone. So what did they find? Well, they found tight blood glucose control reduced the risk of diabetes complications. Specifically, in one subset of the UKPDS 33, they found significant reductions in the risks of microvascular disease, particularly for those treated with sulfonylureas and insulin. A 25% reduction in microvascular disease with tight blood glucose control, a number needed to treat of just 20. And in another subset, UKPDS 34, what they found was those treated with metformin and living with overweight, there was a reduction in all diabetes complications and also a reduction in mortality. So at this point in time, this was the biggest thing that had happened in the world of type 2 diabetes. These studies directly prove that tight glycemic control not only improves quality of life by reducing the complications of diabetes, microvascular complications, but also potentially improved quantity of life by reducing mortality too. So overall, what they found, for every 1% reduction in HbA1c in everyone recruited to the UKPDS trial, there was a 21% reduction in diabetes-related deaths, a 14% reduction in myocardial infarction, 37% reduction in microvascular complications such as neuropathy and retinopathy, and a 43% reduction in amputations or death from diabetes. So again, very compelling outcomes, improvements in outcomes with tight glycemic control, improving both quality and quantity of life. But what was more compelling was, after that original study completed, they followed patients up for another 10 years. So after the study completed, everyone received usual diabetes care from their primary care practice, and they followed up those patients for another 10 years. And what they found after another 10 years was those who were originally in the tight glycemic control arm, so those who were originally treated to a fasting plasma glucose less than 6, still demonstrated improvements in microvascular and macrovascular outcomes, a legacy effect. So those treated with early intensive blood glucose control still had improvements in diabetes complications and mortality even after 10 years of usual diabetes care. And what was even more compelling again, not so long ago in 2022 at the European Association for the Study of Diabetes annual congress held in Stockholm, they incredibly presented 44-year follow-up data for the UKPDS. Now, of course, there weren't many people left in the study, lost to follow-up or sadly passed away. But incredibly, what they found was that legacy effect of early tight glycemic control persists for even up to 44 years. So again, illustrates the benefits of early tight glycemic control, particularly in our younger individuals newly diagnosed with type 2 diabetes, or certainly early on in their course of disease. Okay. In contrast, there's a group of studies which I'm going to pool together just to keep things simple for us in primary care. The CORD study, the ADVANCE study, and the VADT study, all published around 2008, 2009. Now, these studies recruited markedly different people living with type 2 diabetes. They recruited older people, many over the age of 65. Individuals had a longer duration of type 2 diabetes, over 10 years, over 15 years, over 20 years. And they had multiple comorbidities, cardiovascular disease, chronic kidney disease, hypertension. So overall, they were at higher cardiovascular risk. So an iller group of individuals, if you like, than the patients recruited into the UKPDS trial. So they were randomized to very tight glycemic control, actually in some of the studies striving for an HbA1c of less than 6% or less stringent glycemic control. And what they found in these studies, and I've pulled them again all together just to keep things simple, tight glycemic control did not improve cardiovascular outcomes. In fact, in the CORD study, there was a 22% increase in mortality, leading to that study being terminated early. So again, you can see in our older individuals, higher cardiovascular risk with a longer duration of type 2 diabetes. Tight glycemic control did not actually improve outcomes, but instead did harm. So some very important key take-home messages for us in primary care as pharmacists, GPs and nurses. I just want to go over again. For our patients newly diagnosed with type 2 diabetes, living with overweight, or certainly early on in their course of disease, without significant comorbidities, these individuals are likely to benefit from tight glycemic control. So we should be aiming for an HbA1c of less than 48 millimoles per mole, or even less than 42 millimoles per mole, less than even the pre-diabetes range for our younger individuals. Sadly, we're seeing younger and younger people living with type 2 diabetes. There are now more people under the age of 40 living with type 2 diabetes than type 1 diabetes, driven by the obesity epidemic. My youngest patient living with type 2 diabetes is just 22 years of age. So for her, she very much would benefit from early tight glycemic control. So for her, I am aiming for less than 42 millimoles per mole. I'm aiming for the normal glycemic range to minimize her future risk of microvascular and macrovascular complications of type 2 diabetes. However, for my older patients with multiple comorbidities, with significant cardiovascular disease, or particularly frailty, I'm taking my foot off the pedal. I'm aiming for less stringent glucose control. I'm aiming for a higher HbA1c because sadly my older frail patients are less likely to survive long enough to appreciate the micro and macrovascular benefits of longer-term intensive diabetes care. And by this, I mean not just tight glycemic control, but very tight lipid control and very tight blood pressure control. What I'm aiming for my older, more frail patients is, of course, quality of life rather than quantity of life. So, for my older, more frail patients, aiming for a higher HbA1c, 58 to 64 millimoles per mole is appropriate, or sometimes even higher, 70 or even higher in severe frailty. So one size does not fit all. We need to individualize our approach to the management of type 2 diabetes according to that person sat in front of us, their age, their wishes, of course, their duration of disease, and their functional status. Because, as we know, our first principle of medicine is first do no harm, primum non nocere. Another quote for you here by Paracelsus. He was a Swiss-German Renaissance physician and the founder of the discipline of toxicology. He famously said, "Poison is in everything, and no thing is without poison. The dosage makes it either a poison or a remedy." Many of the drugs we use for type 2 diabetes can potentially cause harm, can cause hypoglycemia, acute kidney injury, lactic acidosis, excessive weight loss leading to sarcopenia. So as always, when we prescribe any drug in primary care, we need to balance the benefits against the potential harms. So I wanted to share with you now a great paper by David Strain and colleagues, a great colleague and buddy of mine, talking about type 2 diabetes in the older person. And what this paper very much tells us is that priorities for glycemic control may shift in our older patients to favor safety and avoidance of hyperglycemia rather than achieving strict HbA1c targets. And what I love within this paper is this great table looking at recommended therapeutic targets and treatment de-escalation thresholds. So not only this paper gives us treatment targets for older adults according to functional status, it also gives us de-escalation targets, HbA1c thresholds, when we should be actively consider reducing and stopping treatments. A very holistic, person-centered approach. So for a fit older adult living with diabetes, type 2 diabetes, absolutely aim for an HbA1c of 58 millimoles per mole. But of course, we should be aware of the risk of hypoglycemia with drugs such as sulfonylureas, or we should be aware of excessive weight loss with drugs such as the GLP-1 receptor agonist or the GLP-GIP. Or we should be aware of the potential for euglycemic decay, diabetic ketoacidosis with the SGLT2 inhibitors. I'll be talking about some of these adverse effects in future upskilling training videos. So yes, aim for that tighter HbA1c target. But as we get more moderately to severely frail, then of course take your foot off the pedal. Aim for that higher HbA1c, 64 millimoles per mole, or even higher again, 70 millimoles per mole. And here we should consider drugs that have perhaps a minimal risk of hypoglycemia. The gliptins, the DPP-4 inhibitors. We should revisit drugs such as pioglitazone, thiazolidine diones. I know they're not very widely prescribed these days, but they may increase the risk of heart failure. They increase the risk of osteoporosis and osteoporotic fractures. And there's this possible association with bladder cancer. And again, we should be aware of the potential risks of SGLT2 inhibitors, some postural hypertension, hypovolemia. But that said, even in slightly more frail populations, SGLT2s may provide additional benefits in heart failure symptoms. So I often prescribe SGLT2 inhibitors, even in my moderately frail patients with heart failure, because the symptomatic improvement is seen very early on after starting treatment, as soon as 14 to 21 days. So you can see we need to balance benefits against potential harms, and we need to take an individualized approach. But of course, in most severe frailty, aim for that higher HbA1c, 70 millimoles per mole, or sometimes even higher in very severe frailty and dementia. And here, very much safety is paramount. Quality of life is paramount. So we really should be stopping any non-essential medications alongside all the diabetes, statins for fertility, for example. We should be trying to reduce, simplify insulin regimes, maybe potentially even stop insulin. That's what I've found a lot of the time when my most severely frail patients are admitted to a nursing home environment because of significant weight loss and muscle loss. They really don't need their insulin anymore because of sarcopenia. Remember, muscle is a metabolically active organ too. So often I can very much simplify or even stop insulin in a stepwise manner, of course. I don't want to potentially precipitate DKA, which can happen even in people living with type 2 diabetes rarely. So those are the treatment targets. But as I said, what I also love about this table is the de-escalation targets. So targets that HbA1c where we should actively reduce or stop treatment. So again, for that fit old adult, aim for 58. But if HbA1c drops below 53, consider taking your foot off the pedal. Maybe look, are they on a sulfonylurea or a more intensive insulin regimen? Can we simplify that? Can we reduce the dose of the sulfonylurea? Can we reduce the number of doses of insulin? Look at the renal function. So even if HbA1c drops below 53, take your foot off the pedal, revisit that drug regimen. Moderate to severe frailty, as we said, aim for 64. But if HbA1c drops below 48, again, revisit that drug regimen. And in very severe frailty, yes, aim for 70 millimoles per mole. But if HbA1c drops below 64, revisit that drug regimen. So very holistic, very person-centered, and allows us to take a bespoke approach to setting HbA1c target according to functional status. Age is just a number, isn't it? What is more relevant is functional status. So this cartoon, this infographic also nicely illustrates an individualized approach to managing hyperglycemia, to individualizing HbA1c target. This is drawn from a number of sources, including the ADA, the American Diabetes Association, guidelines from a number of years ago now. So it sets a range of HbA1cs from intensive, less than 42 millimoles per mole, as I already said to you, for my youngest patients, my functionally independent patients, to a more relaxed HbA1c target, over 64. So it asks us, it challenges us again to look at a number of factors. Most important of all, what does the patient want? So we need to respect that individual's autonomy. What is their attitude? What is their expected treatment effort? Are they a highly motivated individual? So are they happy to take regular medications, multiple medications? Do they have an excellent functional status? In which case, absolutely aim for that tighter HbA1c target, less than 48 or even less than 42. However, if they're less motivated, if they're unable to take medications regularly, if they're unable to care for themselves regularly, if they're functionally dependent, take your foot off the pedal and aim for a higher HbA1c. What is their risk of hypoglycemia? Do they live alone? Are they vulnerable? Is it high? Then, of course, we should be avoiding too tight an HbA1c target. But if hypoglycemia risk is low, we can aim for those tighter HbA1c targets. Disease duration, we've covered this already. Remember, in UKPDS, people were newly diagnosed with type 2 diabetes and did see benefits from tight glycemic control. But in those other studies, the VADT study, the advanced studies, people had a longer duration of type 2 diabetes, and tight glycemic control did not show benefit. So we take a foot off the pedal for these individuals. Life expectancy, of course, in our more frail patients in a nursing home with severe frailty, sadly, life expectancy is short. Treatment, especially tight glycemic control, is going to be futile. We need to aim for quality rather than quantity of life. Important comorbidities. If people are very early on in their course of disease without significant comorbidities, absolutely aim for that tighter glycemic target to prevent the development of these comorbidities. But if patients are frail with multiple severe comorbidities, then aim for a higher HbA1c. But of course, we're now aware of specific properties of many of the newer therapies, SGLT2s for CKD, for heart failure, GLP-1 such as semaglutide for atherosclerotic cardiovascular disease. So this is where some treatment decisions can become a bit more complex. But ultimately, if someone is more functionally dependent or frail, we should not be starting a treatment that might potentially cause harm. Similar situation with those with established vascular complications. And finally, what is that individual's resources or support system? Again, do they live alone? Are they vulnerable? Do they have carers coming in? Are they reliant on the local district nurse coming to administer insulin, for example? This will also affect what HbA1c target we aim for. So to finish off, I'm just going to take you through a quick case study about some of the potential pitfalls of HbA1c. This is one of my patients, Paul, 58-year-old gentleman, living with type 2 diabetes for 5 years now, alongside a diagnosis of hypertension, another common comorbidity. His BMI is 26. His waist to height ratio is 0.54. As many of you will be aware, there's been a real shift away from BMI to waist circumference and waist to height ratio. So in an ideal world, we should all have a waist circumference of less than half our height. So waist to height ratio of less than 0.50 is a healthy waist to height ratio with a low future risk of cardiometabolic complications. A waist to height ratio of 0.50 to 0.59, you're at increased risk of cardiometabolic complications, and a waist to height ratio of 0.6 and above, you're at high risk of cardiometabolic complications. Paul is of Scottish Caucasian background and has a family history of bowel cancer. His current treatments are a combination tablet of metformin 1 gram and empagliflozin 5 milligrams, which he takes twice a day, atorvastatin 20 for the primary prevention of cardiovascular disease, and losartan 50 for his hypertension. His current numbers, HbA1c 74 millimoles per mole and a home blood pressure average of 129/79. Pretty respectable. He attends for his diabetes review with me because he's pretty frustrated with his recent HbA1c 74, because his blood sugars at home are around 78 millimoles per mole in the morning, and he's also lost several kilograms in weight recently. So, what do you do next for Paul? Do you reinforce that all-important lifestyle advice, encourage further positive lifestyle choices, weight loss? Ask him to maybe check his blood sugars 4 times a day. He self-funds blood sugar testing strips at home because he's quite motivated to improve his blood sugar control. And do you simply repeat his HbA1c in 3 months? Or do you intensify his treatment? Do you increase the dose of his empagliflozin to 25 milligrams a day? Would you add in a third line oral hypoglycemic agent, a gliptin, pioglitazone, an oral GLP-1? Or would you add in an injectable agent, a GLP-1, tirzepatide, or consider basal insulin? Would you phone a friend, refer him to the weight management service? Or would you do something else, maybe check some bloods? If so, which ones? I elected to check some bloods, and sadly, his full blood count revealed an HB hemoglobin of 79, an MCV of 61, and a ferritin of less than 5. His hematimics, vitamin B12 and folate were normal, so I referred him for urgent gastrointestinal investigations, which revealed a sigmoid cancer. Remember, sadly, he had that family history of bowel cancer. So this is where I wanted to quickly highlight when we should interpret the HbA1c with caution. There are 2 key scenarios. Any condition that potentially affects red blood cell lifespan. Anyone remember how long a red blood cell lives for? 120 days. It's still one of those useless facts I remember from uni. So anything that affects red blood cell lifespan either prolongs it or reduces it, or any condition that affects hemoglobin structure, thalassemia, sickle cell anemia. So this cartoon illustrates some of the commoner conditions we might come across in primary care that may invalidate the HbA1c. Chronic iron deficient anemia. In those with a chronic iron deficient anemia, like our patient Paul, your red blood cells live for longer. So they circulate for longer, they're exposed to glucose for longer, so you get an artificially elevated HbA1c. Whereas in bleeding disorders, hemolysis, acute blood loss, your red blood cells live for a shorter period of time, so they circulate for shorter, they're exposed to glucose for a shorter period of time, so you get an artificially lower HbA1c. And as I've said already, anything that affects hemoglobin structure, thalassemia, sickle cell anemias, hemolytic anemias, all potentially lower your HbA1c. So chronic iron deficient anemia, vitamin B12 deficiency, thalassemias all increase your HbA1c potentially. Hemolysis, acute blood loss, CKD and hemodialysis, hypertriglyceridemia, recent blood transfusions, and hemochromatosis and venesection all potentially artificially lower your HbA1c. So the other big clue was the mismatch between his HbA1c and his home blood sugar levels. Remember, his HbA1c was 74. So at 74, we would expect average blood glucose readings to be about 12 or even higher, whereas he was getting morning blood sugars of 7 to 8. So again, treat the person, not the number. If you see a mismatch between HbA1c and blood sugar levels, just think, could there be something else going on? And he'd also lost several kilos of weight, but his HbA1c was still high, 74. So treat the person, not the number. So what nice NG28 tells us is that if there is a condition that might potentially invalidate HbA1c, consider the use of quality controlled plasma glucose profiles, which you can discuss with your lab, total glycated hemoglobin, or what I tend to use is fructosamine. Fructosamine is an alternative measure of glycemia that looks at glycemic levels over a shorter period of time, maybe the last sort of 4 to 6 weeks or even shorter, if HbA1c is unsuitable. I can't get fructosamine levels down in my Edinburgh lab, so the samples have to be sent down to an English lab actually somewhere. But it is good for people where HbA1c is potentially invalid. So I'll finish up there with some key take-home messages. Our older, more frail individuals are less likely to survive long enough to appreciate the micro and macrovascular benefits of longer-term intensive diabetes care, tight glycemic control, lipids, BP. So take your foot off the pedal, particularly in terms of tight glycemic control. Lipids are less important. Aim for a higher LDL and aim for a higher blood pressure to avoid harm. And what we have now are recently published consensus statements that recommend treatment goals, treatment targets, but also importantly de-escalation targets at which we should actively reduce or stop diabetes drugs according to frailty status in older adults living with type 2 diabetes. So for our older, more frailer patients, aim for that higher HbA1c, 58 to 64. Or in severe frailty, even higher, 70 millimoles or even higher might well be appropriate. So thank you for listening, everyone. I hope you found that session helpful. Please feel free to get in touch by email or social media if you'd like me to clarify anything or have any further questions or comments. Thanks for listening again.